For lunch, we'll get ready with our first afternoon session, which is going to be very exciting because we're going to have the opportunity to look and hear some of the abstracts that have been submitted to the ISNVD. And we're looking first for Dr. McGuckin. Here he comes, all set. James McGuckin is going to be the first presenter, and he's going to be talking about recanalization of the jugular vein and CCSVI. And each speaker will have 20 minutes to start with. First, he's going to get his microphone on. Well, this says the next two speakers have 20 minutes. Yeah. First two.
Good day, and Dr. Zamboni, it's a pleasure to be here. I have a couple disclosures. I'm the founder of Rex Medical and also the founder of Vascular Access Centers. Today we're going to be talking about the good, the bad, and the ugly of CCSVI. Some of the findings, some of the responses to this treatment are amazing, but there are also some downsides that we need to know about and talk about it. So let's talk about incidence of jugular vein occlusion. I take care of patients that come from all over the world. We've had patients from the Far East, patients from Europe, Canada, South America, and I see a lot of complicated cases. The thing that's critical is that these patients come from all over the world, but what's their follow-up when they're treated all over the world? Was the patient on anticoagulation when their jugular vein occluded? If jugular vein occlusion occurs, is it a primary case or is it a secondary case, and was there a stent placed? If there was a stent placed, was it a bare metal stent or a covered stent? So let's talk about the patients. The patients of CCSVI, it's typically a social network-driven disease. The patients travel all over the world. It's because of various reasons. We know about Canada, of course, but patients travel from many different countries to get treated by physicians. So there's the international aspect of not only the travel, but the care and the follow-up, and also how do they afford care in those countries. Quality of care, I think it needs to be addressed. I've seen many cases where I follow up patients and I see lesions that have missed. So I think we really need to put our time in for these patients to make sure we do an adequate diagnostic study before we treat. So I'm leading into my next slide. Thorough examination of these patients is critically important, and we talked about the diagnosis before we treat. We must carefully dilate without rupturing a vessel or causing a dissection. We know that venous pathology can lead to severe stenosis if there's a rupture or a transection or extravasation. So we have to be very careful to get adequate dilatation of the stenoses without leading to rupture. It's my belief, and this is my belief alone, that primary cases should not be stented in general. I think we have to do our best to do basic angioplasty on these lesions and see how the patient does post-procedure. I really think stenting, having seen the complications related to stenting, we should avoid that unless the patient needs it in a secondary scenario. Let's see how they do with basic angioplasty alone, and then if we have to, stent as necessary. I also believe that we should not dilate J3 lesions, so lesions above the facial vein going up to the skull base, unless it's absolutely necessary. And in that sense, only after J1, which is the valve plane, or J2, inferior to the facial vein lesions have been completely treated. So let's talk about that. When we see commonly we see the atlantoaxial compression on the J3 lesion, and I think that often goes away if the lower or the inferior lesions are treated. So be careful about that, and let's monitor that carefully. Stenting in J3, we have to recognize that it can lead to cranial nerve 11 palsy and pain distributions, and this can be very debilitating for patients. So I recommend also, if there's a subsequent lesion in J3 that needs to be treated, let's try to treat that with just angioplasty alone. Follow-up care. We need standardization. It's important at meetings like this that we talk to our colleagues and figure out what's working and what's best. Because when patients are released and they fly back home, what is their follow-up care? Is there a pattern? Do they just follow their symptoms? Do they get ultrasound? Do they get MRV? If they're on medications post-procedure, what's the regimen that works? Is it aspirin? Is it Plavix? Is it Coumadin / Pradaxa, or a low molecular weight heparin? So consistency and follow-up is going to be very important, because when we combine our data sets and we try to make science of our procedures and our data, consistency and how we can group these patients is critical. So we talked about follow-up, but also what's the best cost-effective imaging tool? Is it Doppler? Is it MRV? And where are we looking? What vessels are we looking for follow-up? The other thing I want you to know is that having seen hundreds of patients, it's my belief also that the patients that have had the benefit from the procedure, so that 80+% that actually benefit from the procedure, if they happen to have restenosis or if they lose their advantage of the procedure over time, I've never found them to be wrong venographically. So I think it's important to trust your patient's symptomatology. If they've had the advantage of the procedure and then they lose the advantage, I think they're often going to be right that they've actually had restenosis. So let's talk about a couple cases, and I'll run through these. Here's a J1, J2 occlusion. So I've got a stent occluded right at the left base there, at J1, J2, and I'll do a diagnostic study. So there's an indwelling stent. And this is an oblique view and an AP view. So AP view, the left jugular vein is occluded. You see the brachiocephalic and the subclavian. On the oblique view, you see the vertebral coming off posteriorly. You see the external jugular and an anterior cervical. So that's the oblique view confirming the thrombosis. And obviously you're probing that. You can't get into it. Common things are common. So what I do typically is I'll put a snare at the base of the segment in the brachiocephalic vein. So I've got a loop snare at the base, and I've already gotten access to the J3 segment of the jugular vein. And when you inject that J3 segment, here's a venogram. You can see massive collaterals. This is all draining collaterals, and you see a very small kind of a membranous kind of expression of contrast around the occluded stent, all consistent with a vascular thrombosis. Now, when I call it cold means cold recanalization. So when I'm trying to use classic wire and catheter technique and actually can push across the occlusion. If I can't get across, then I'll use hot recanalization. We'll use a radiofrequency powered wire to cut across the occlusion. So the cold technique is just mechanical force, and I'm through a sheath at the J3 segment, and I'm pushing down with a catheter and wire with a buckle technique so I don't go through the sides of the stent, and I push into the occluded vein. Now often the cold technique will not be enough to complete the recanalization, and I'll have to switch over from cold technique to hot technique. And this is what we're doing here. You can see this little dot at the bottom of the screen. That's the tip of the Baylis power frequency wire. And what that is like a little flamethrower, literally. And it'll cut through any kind of fibrous tissue. It does not cut calcified tissue, so it will not work very well in arterial occlusions. But in venous disease, where it's thrombosed biomaterial, it'll cut right through there. And I'll actually pass the hot wire tip into the snare, and we'll use bidirectional imaging. I heard some issues about quality imaging. This is all done on a portable C-arm with same resolution that we have in hospital-based units. But we'll catch that snare wire, and this is the oblique showing me that I'm still in line inside the stent, and I'll advance it through the loop from two different projections, and then I'll snare that out the groin. The wire has been taken from the neck all the way out the groin, and obviously serial inflation by angioplasty. Typically there's a stenosis at the top and also a stenosis at the bottom of the stent. So here's the one inferiorly, here's the one in the cephalad aspect, and after complete dilation of angioplasty, I'll obviously have recanalization, and at that point we go ahead and inject, and I'll get patency of the segment. Here's a case where there's J3 occlusion, so it's a different scenario. It's the occlusion at the level of the skull base down to the facial vein, and obviously the occlusion is on the right side. This is the facial vein that's just already enlarged, draining the siphon via collaterals. The left side's patent. And here's an oblique view confirming the same thing, facial vein down to the J1 stump, but the occluded J3 segment. And these cases are far more difficult because I have no cephalad access. So I have to probe, obviously, from below going cephalad. This is two views of the same right jugular vein. Here's the J1, J2 stump. Here's the facial vein that's enlarged coming off. Here's the AP view. Here's the oblique view. And there's the stump of the occluded J3 segment. And this time, I just have to go with cold technique, right? I'm going out with catheter and wire and a very rigid, 8-French sheath right behind it to give it support. I call this analogy my base camp because I'm bringing my base camp up higher and higher till we get to the apex. But by advancing wire and catheter up, I'm able to get up to the base of the skull, obviously inject my siphon. I pass my wire into the jugular foramen up into the transverse sinus, sigmoid sinus, and there's AP and oblique projections confirming the wire position's correct. And after that's injected and proved, you can see this massive congestion in the collateral flow. And after angioplasty at the level of the skull base, that's a 6 millimeter balloon, I'm able to achieve patency here with just angioplasty alone. We did not stent this upper segment. But there's a good antegrade flow once we've had recanalization. So my success at these J3 occlusions is only 25%. They're very, very rigid, and the issue is I can't use the radiofrequency. I haven't used the radiofrequency to go inside the skull base, but it's very resistant, specifically if there's occluded stents at the level of the J3 segment. So when we talk about J1-2 occlusions, we're jumping back a little bit. This is an MRV of a patient's head. You can see this massive congestion going on. This is far too much venules that we're seeing on this basic MRV projection. And at the neck level, you can see obviously there's a left IJ occlusion. There's a massive dilation of the left external jugular. And I've got collaterals on the right side as well. And this is just a view with different time of flight showing the occluded left segment. And when I inject the left subclavian, left vertebral region, you get this massive dilatation of the left vertebral muscular complex given the occlusion on the left side. And when we get J3 access, so now I'm J3, I'm injecting inferiorly, you see that anterior cervical or thyroidal collateral, and you see the occlusion at the J1, J2 segment. And with cold technique, I'm using catheter and wire, and I'm advancing back down to get to this level. So here's the wire and catheter going inferiorly. And you think you're there in the AP projection, okay? I have a catheter from the right groin up to the left brachiocephalic. I'm coming down from the neck. You think you're there. I do an oblique view. So now it's a very steep oblique view. And once again, it confirms that I'm right there. I'm knocking. But when I advance my catheter down over that wire, I'm still not true lumen. I don't have flow. So I'm literally, a wall or partial wall thickness away from getting to the true lumen. And only when I convert to radiofrequency am I able to get back into the true lumen. So once I've snared that, and literally, it's one touch of the power, I snare it, I'm out, angioplasty alone, and then after angioplasty and stenting, you've got inline flow and patency from the left jugular through the occlusion. J3 stenting, these are very difficult cases like I mentioned. I've only been able to get through 2 out of the 8, but they're very, very challenging because the need to go cold. I don't feel any comfort at all going up with the radiofrequency wire towards the skull base. But when we're able to get through and we're able to angioplasty and stent, we get a good result. Now, what's a good result? A good result is antegrade flow, and I think at least a 6 millimeter diameter patency. I'm scared to go any higher than that at the jugular siphon or foramen, and I'm interested to know, Dr. Dake, Dr. Zamboni, what your thoughts are. But there's only so much volume there, and I'm very concerned about obviously intracranial hemorrhage if we dissected the dural attachment. So in summary, I think it's critically important that we must diagnose before we treat. I don't say that lightly because I see cases from all over the world, and I think we really have to be careful and do our diagnostic work and be really thorough in our examinations. Once again, we must dilate without rupture or dissection to prevent restenosis if possible. And I'm a strong believer that primary cases should not be stented in general. There are cases where you're going to have to do that, but I want you to think about it carefully before you do stent, because these stents that we do lay, they do go out, they do go home, and patients have to deal with these consequences. Sometimes stents are life-saving and obviously critically important, but I think we have to use them judiciously. I don't think we should dilate J3 stenoses unless it's absolutely necessary, and only after J1 and J2 lesions have been completely treated. We do have to know that stenting in the J3 can lead to cranial nerve 11 palsy and pain, and they do have a high risk of thrombosis in my experience. Recanalization of the jugular veins can be accomplished safely. Antegrade access, if it's achieved in the J3 segment, I've been successful in recanalizing J1 and J2 thromboses in 100% of patients, in 13 out of 13. But 11 out of the 13 required conversion from cold to hot therapy with the Baylis radiofrequency power wire. And one thing I want you to remember too is that recanalization of J3 segments is very, very difficult, and I think it takes a whole other level of care and experience. And I've only been successful in 25% of those, and I think that's because I'm not able to convert to the radio frequency wire. Thank you very much.
Yes, questions for Dr. McGuckin?
You talk about recanalization through thromboses. What about hyperplasia?
By venogram, I can't tell the difference, and it's really no different for us to cross one or the other.
I'd say at this point, this is the most common problem that I see, is either a clogged stent or a completely scarred down upper jugular. And so you've said that you've had really good success with the RF ablation. I'd like to sort of, you said 2 out of 8. I think that's a really key issue, because I gather not everyone agrees with RF ablation. I've heard some people just in the hallways say they don't like it at all. So I really would like to hear what you have to say about this, Adnan. I think it's a really key issue, and is it really that you just don't want to use the RF ablation at the top, at the J3, or is it also a technically difficult issue?
Personally, for me, I mean, background's important. After Mike's seminal article in the literature, I did the first thoracic stent graft, homemade, like the week after it came out. Did 65 carotid stents before protection. Very aggressive interventionalist. I think taking a miniature flamethrower towards the brain is frightening to me, and I'm just man enough to say it scares me. I really think I think we shouldn't stent in that location. I really think we should try to avoid it. If the occlusion does occur, I go hot 90% of the way, and then I go cold. And if I get through, then I'm successful. And if I fail, I accept my failures. I think at the end of the day, we have to do no harm, and I think we can do a lot of harm going too far. So I think you have to limit yourself.
How often do you observe a reocclusion after successful opening of occluded stent?
It's a great question. It's definitely happened. I do know 2 patients so far that has reoccluded. The critical thing for me is when we dilate these regions up, it's all about flow in the venous system. You need flow to maintain patency. We all know that. And anticoagulation alone post-procedure does not seem to be enough in my experience, because these patients have been anticoagulated. I know they're disciplined. I know they took their medications, aspirin and Plavix, and still it's not enough. So, my question is, do we add that extra regimen? Do I put low molecular weight heparin on board? These are things that I'd like to talk to colleagues about, because at the end of the day, having gone through all these efforts to recanalize someone and have them rethrombose is horribly disappointing. But I want everyone to know that's treating these patients around the world, when you let those patients go home, I think it's important to know that you don't know how they're doing. And we all want to think they're doing wonderfully, but the reality is they're not. And we have to think of how we're going to do a better job in the future.
In our observations, this reocclusion often seems to be to poor inflow. But you cannot, in some cases, improve this inflow because of this array anatomy of intracranial.
Well, I think you make a great point, because once you stent, obviously it's going to have increased vascular resistance. So the flow is going to be obviously towards the opposite side or to your collaterals, because there's less flow. And don't forget, those collaterals were there before you recanalized. So it's a real challenge of pathway of least resistance. And I think anticoagulation is the only scenario that I can think of that would help us. But don't forget, I've got to pull a sheath out of the neck and a sheath out of the groin. I'm not worried about the groin, trust me, but the neck, how hard do you press that with extrinsic compression to maintain the flow through the vessel you just recanalized? So these are all trade-offs, and it's challenging at best.
I have a lot of questions, but I think we better limit to one last question to stay on time.
Just technically speaking, how do you get your access retrogradely in terms of a collapsed jugular vein that's not really there? Or any tips or tricks that you're using to get them?
You'd be surprised. They're there. You just got to use ultrasound. And my real recommendation is taking a stiffened 501, a cooked 501 micropuncture, and I put a little curve on it, like a little J curve, because when you make that excursion into the vein, you want it to be nice and smooth. And having a stiffened micropuncture is everything.
The other only comment, just to respond to Dave, I absolutely agree with you. I've seen one case of an intracerebral hemorrhage directed primarily in the posterior fossa, where there was an attempted recanalization, opening up an occluded stent in the J3 segment where the radiofrequency wire. So it is possible those dural, the jugular bulb is the thinnest part of the dural sinus.
Absolutely.
It is the thinnest part. It doesn't take a whole lot for you to go through. And as far as cranial neuropathies, haven't seen that as well, so I absolutely agree with you. Trying to oversize beyond 6 millimeters is asking for trouble.
I appreciate that.
Thanks very much for everyone's comments, but I think we'll move on. Paulo?
Thank you.
Dr. Cohen from Geneva, Switzerland. CSVI in multiple sclerosis is characterized by altered collagen expression in draining veins in the brain.
Good morning. Do you hear me? Yes. First of all, I'd like to thank you, the organizers of this Congress, for this wonderful Congress and for giving me the opportunity to show you the results of on this subject. I have no conflicts of interest, and this work has been funded by different sources: the Swiss National Science Foundation, the Italian Multiple Sclerosis Foundation, and the La Reichert Foundation. Well, I will say nothing new here. There is a present and ongoing debate that regards the existence or not of the cerebral venous outflow impairment in multiple sclerosis due to anomalies of the izigus or the internal jugular vein. What we wanted to do is to study the morphological and biological features of the internal jugular veins in multiple sclerosis patients. So let's start with what we have been given, so what we've studied, with what we began to study some years ago, thanks to the collaboration with Paolo Zamboni and the Bellaria Hospital. We received specimens from 4 patients with multiple sclerosis and CCSVI diagnosis. This patient underwent percutaneous transluminal angioplasty, the liberation procedure, but after some months they underwent restenosis. So what was proposed to these patients, and they accepted, was to make a reconstruction of the internal jugular vein with the great saphenous vein. So thanks to that, we obtained 5 internal jugular vein specimens, because one patient was operated bilaterally, with macroscopical lesion. Most of all, they were thickening of the vein wall. And what I want to draw your attention on the fact that, of course, here you can see the ballooning, here you can see the annulus where the ballooning was done. And what we studied for histology was this area, so the zone that is much more distal, that is much more near the skull and the brain, because we didn't want any interfering to our histologic analysis due to the ballooning effect. Moreover, we could collect 2 great saphenous vein specimens that were samples of the great saphenous vein used for reconstruction. And we called this specimen the diseased treated internal jugular vein and the undiseased great saphenous vein. Moreover, and that was of pivotal importance for our study, we, once again, thanks to Paolo Zamboni and Dr. Salvi, we could have materials from one unlucky patient with multiple sclerosis in which CCSVI was not tested, so we didn't know if he had or not CCSVI, who died because of a hemorrhagic stroke due to a ruptured cerebral aneurysm. You can see here that we had a lot of tissue to analyze. So what we did was that we went up searching for pieces of the internal jugular vein, specimens of the internal jugular vein that had microscopical lesions that we have already observed, that is, thickenings. And so we sampled 3 internal jugular vein specimens with macroscopical alteration, and we called them diseased and treated internal jugular vein. But we found out that we could not see along the whole length of the internal jugular vein these thickenings, so we could collect 3 internal jugular vein specimens of the same patient without macroscopical alteration, and we called them undiseased, untreated internal jugular vein. And finally, we sampled 3 non-internal jugular vein specimens without macroscopical alteration. So we collected them here and here, so there were 2 pieces of the brachiocephalic trunk and 1 coming from the superior caval vein. Here is just a close-up of what we sampled at the level of the internal jugular veins. Here are the clinical features of patients with MS. You can see the first one is the patient that died, and we don't know which type of lesion he had. And just draw your attention on the patient number 5 that was bilaterally treated. And we needed controls, so we started to collaborate with the pathology department of Geneva that gave us kindly specimens of internal jugular veins from autopsy material of 8 patients that had not multiple sclerosis or other neurological disease, and we call them the control IGV. Moreover, thanks to the collaboration with my former director, Dr. Mascoli, we could collect surgical material from the external jugular vein. There were specimens obtained during fashioning of the external jugular vein patching for common carotid endarterectomy, and we call them 2-AGV, control AGV. Here are the clinical features of control patients. Before someone asks, yes, I'm aware that the age, they have old age, they're a patient with old age. The 2 here are the patients who were operated for carotid endarterectomy. It is not specimens, it is not autopsy specimens. But before talking about our findings, we should remember what Freud said. He said that the anatomy is the Schicksal, I don't know if it's right, but means anatomy is destiny. So we should, first of all, think about the anatomy and the histology of the internal jugular vein. And as a matter of fact, Sigmund Freud was a student of Charcot, and the nanny of Sigmund Freud suffered of multiple sclerosis, but at the time they thought there was a psychiatric illness. So let's go straight to histology. We are all aware that veins are not arteries. They are very different in terms of functioning and of structure, but not a lot of people know exactly the structure of vein histology, and we were the first that were very surprised to study how the vein differ from arteries. You all know that arteries has a small intima, a big media full of smooth muscle cell, and the adventitia that is devoid of smooth muscle cell with scattered fibroblasts. That's not the case of the vein. In the vein you see, once again, a small intima, but a very, very, very thin media with smooth muscle cells that are circumferentially oriented, and a big adventitia. And surprise, the adventitia is full of smooth muscle cells that are in longitudinal bundles. So you can see here the main components of the different laminas, and the most important one in terms of number of contents are smooth muscle cell and collagen fibers. Smooth muscle cell actually is the main interest of the lab in which I work. You all know that smooth muscle cells are the most abundant cell type in blood vessel walls. They have a muscle-like morphology, and they contract in response to mechanical and biochemical stimuli. So they control blood pressure and blood flow. And most of all, smooth muscle cells in vessel are the cells that produce collagen, elastin, and proteoglycan. So there is a crosstalk between smooth muscle cell and collagen. How to differentiate smooth muscle cell from other cells? Well, by using cytoskeletal markers. You see we have a plethora of cytoskeletal marker from alpha smooth muscle actin. That's the first marker that appears, to smoothulin, that is the last one. For our purposes, we studied alpha smooth muscle actin, that was described in Geneva for the first time, and it is the most general marker of smooth muscle lineage. So if a cell has alpha smooth muscle actin, it is smooth muscle cell, no way, or it is myofibroblast, but it's well, far from what we discussed today. And smooth muscle myosin heavy chains that comprises isoform SM1 and SM2 is a marker of well-differentiated smooth muscle cell. And collagen. Collagen is even a more complicated subject. We have at least 28 different collagens in vertebrates, and it's the most abundant protein in mammals, together with the actin. It is the major protein of the extracellular matrix, and it gives structural scaffold. And in blood vessel, we have most of all two types of collagen, collagen type 1 and type 3, that are called fibrillar collagens, that are synthesized, as we have seen, by smooth muscle cell. Collagen are composed of, of 3 alpha chain, 3 polypeptide alpha chains that are called together, like a triple helix, that are around one another in this triple helix, and they have a typical amino acid composition with these triplets composed by glycine, proline, and hydroxyproline. Then collagen fibrils can stick together and form bigger collagen fibers. But what we should take home as a message is that the type 1 collagen is synthesized by different cells and in different tissues, but most of all it is densely packed in thick fibers, and that can have marked variations in diameter, and it's resistant to tension. Whereas type 3 collagen, what is also called the immature collagen, but it's not true, is loosely packed, has loosely packed in fibers that with more uniform diameters, and gives structural maintenance in extensible organs. Why are they important? Well, once again, we have a crosstalk because type 3 and type 1 collagen can colocalize in the same fibrils, and type 3 collagen plays an important role in type 1 fibrillogenesis. If there is no collagen 3, there is badly formed collagen 1. And that's very important. There is a very elegant study published in '94 by Baskin on the bladder of mammals' bladder, bovine bladders actually. When they have studied that in development, the type 3 to 1 collagen ratio changes according to the different physiological requirement of organs. That is that the amount of type 3 collagen diminishes with fetal development and inversely correlates with bladder compliance. So more collagen 3, less developed, more stiffness, more collagen 1, more developed, more compliance. And last but not least, we should remember that collagen has intrinsic birefringent properties. Why is it important? Because this allowed us to make our studies. It means, what does it mean, birefringence? It's very, very complex, but just we can summarize that it can selectively interact with polarized light, so while the light waves vibrate in a single plane, and it is visible by polarized light microscopy. Aware of this, we used, moreover, a dye that's called the Sirius Red. That's a birefringent molecules, once again, that binds to the triplets we've seen before. And so we have 120 molecules of Sirius Red that binds to our triple helix, and so the birefringence is enhanced. That means that if we look at collagen with a normal microscope, all we see is red fibers on a pale yellowish background. But since collagen is a birefringent, if we use polarized light, we have this one, that the light we see can be much more red-yellow. That's typical of large, tightly packed, more organized fibers that correspond to collagen 1. And or green, yellow-green, that's small, loosely packed, less organized fibers, typical of collagen 3. So from green to red means that we have a variation diameter and packing of collagen molecules. So let's go back to the histology in the few last slide. The histology of internal jugular vein was a little bit, we were a little bit sad in the beginning because hematoxylin and diosine and other common staining were exactly the same. You see a normal structure. They are identical. So we said, oh, that's a pity. But then we said, okay, let's study collagen. Maybe it plays a role. And here you can see that under unpolarized light, you can already see that something strange is here down, but you see that the fibers are more wavy. But if you use polarized light, then you have the answer. In control veins, you have a prevailing red birefringence, and in multiple sclerosis vein, you have a prevalent yellow-green birefringence. And we quantified it, so that's a bit complex, but I'll try to tell you. Just look at the red and the green, that's the important thing. You see that in the control, both internal and external jugular vein, you have much more red. In patients from multiple sclerosis, in the lesions that we have called them undiseased, so we couldn't see any thickening, you see once again a prevailing red birefringence, both in the internal jugular vein and in the non-jugular vein specimens. If you look at the multiple sclerosis diseased patients, whether if they were treated, so they underwent PTA, or they were untreated, so the patient that we call patient 0, the patient who died of an hemorrhagic stroke, you see prevailing green. What's important is that in the great saphenous vein that were taken from the patient who underwent PTA and surgery, you have a normal red birefringence, so it means that we have a variation of collagen, but it's very, very focal. What about smooth muscle cell markers and type 3 collagen by immunohistochemistry? You see that control and MS are exactly the same, There is no difference in the differentiation marker. You can see here alpha-smooth muscle actin that stains the media and the adventitia, the same by myosin heavy chain, so they are very well differentiated smooth muscle cell and no differences. And collagen 1, actually that's quite interesting. We don't see differences in staining and in area of expression of collagen 1, but we have much more weaker staining in control veins and a smaller area of expression in control veins if we compare it with multiple sclerosis veins. So it is not the collagen 1 that goes down, but is the collagen 3 that stays up. And finally, we are all aware that multiple sclerosis is an inflammatory disease. Well, nowadays, everything is inflammatory disease, from atherosclerosis to cough, I would say. Well, cough it's true, it's, you have inflammation. And what about, we studied the pan-T cell marker, CD3, no differences between control and MS. You see the difference between 2.5 cells and 3.4 cells, so no inflammation, and the same thing was for macrophages, no macrophages in the vein wall. And finally, this is, well, I decided this night to put this, it's a tribute to Paolo, because we discussed a little bit about azygous vein. Unfortunately, we have just few azygous vein. We could just collect one azygous vein from the patient who died of hemorrhagic stroke. But it's quite interesting, because you can see here that, here is what we studied. You can see here that we have actually two portions. We have a more upper portion with a typical twisting of the azygos, and a normal, well, I would say a little bit dilated portion of the azygos, but it's maybe due to the stenosis that's up there. And if we look at the dilated but I would see normal portion, it's maybe a compensatory dilation, you see once again prevailing red, and if you see the yellow-green collagen is 44.9%, but if you look at the twisted part, you have a prevalence of yellow-green collagen. So the yellow-green collagen is 71.8%. This is not statistical, it's just a special disclosure for this Congress. So the conclusion is that, the take-home message is that, look at the adventitia, and you will see that the adventitia of normal veins have prevailing orange-red birefringence corresponding to type 1 collagen, while the adventitia of multiple sclerosis veins, wherever they come from, has much more yellow-green birefringence corresponding to type 3 collagen. So this hallmark of MS vein is a focal, you've seen it, and maybe constitutive alteration of the ECM, because we don't see no inflammation and no fibrosis. Someone can ask, well, is it fibrosis? No, because we don't see any myofibroblast. We don't see angiogenesis, and you've seen what said Dr. Alexander the other day. And so there are no hallmark of fibrosis whatsoever. That's why we think it's a constitutive alteration. Interestingly, similar alterations have been described in different unrelated conditions, like the paraesophageal hernia and the skin incisional hernia. But much more interesting, I would say, is that the lower collagen 1-to-3 ratio, so low collagen 1 and high collagen 3, is associated to impaired anastomotic colon healing after surgery and loss of compliance in dysfunctional bladders. So the hypotheses are two. Do we have reduced mechanical stability in these cases? And if we have this, does this play a role in the hemodynamic alteration described in MS patients with CCSVI? Of course, further studies are needed to investigate the correlation between the venous changes and MS pathogenesis. I'd like to thank Marie-Louise Beauchaton-Piallat and Giulio Gabbiani, my mentor, and of course Paolo Zamboni and Erika for the collaboration, Fabrizio Salvi and Francesco Mascoli. And thank you all, both for your attention and because it was very nice after 20 days in Geneva with the weather like this to come here in Florida, where it was minus 15, minus 20 and big wind. So thank you very much.
Questions for Matteo? Robert?
Excellent.
Thank you.
We just need more of studies like this. Can you speculate if you have type 1, I mean, in how much time can the same tissue become type 3? Is that possible? What are the, mechanisms that can switch of type 1 to type 3 or vice versa? I don't know.
What we know, it's typical of wound healing. For example, you have a vessel that's been studied by cardiologists. You have a vessel, Then you make PTA. So normally in the vessel you have much more collagen 1 and less collagen 3 because it's important, collagen 3. But then what's up is that you have the collagen 3 that goes up and the collagen 1 that, I mean, the ratio, of course, goes down. But in just a few months, you have a complete remodeling of the tissue, so it's just that collagen 3 opens the way to normal reparative process. But after a few months, you have the collagen 1 that goes there. And this is accompanied, paralleled by the appearing of myofibroblasts, the appearing of new angiogenesis. So and it is due to some mechanical stimuli that happens, cells are activated, and so on. That's why.
Is there any literature on this point? I mean, did somebody investigate it, genetic markers, then genes which could be, connected with that, or I don't know. I'm just asking.
Not really. There is something. I mean, the paper. I mean, there is something in a different field, in urology. They've studied this bladder, dysfunctional bladders, and they've studied that in dysfunctional bladder, even the messenger RNA for collagen 3 is up. So we have something that happens in the neurogenic bladder, for example. It's what we have, but no more than that. And I think that the studies, we had a peak of studies around 94, 96, and then nothing else. But something has been done. I mean, it's a classical activation pathway, but it is an activation pathway. Then it goes away. Here it does not go away. It's already here. That's, we think.
Let me ask you, Matteo and Paolo, about, there's some literature about the collagen subtype composition in varicose veins.
Yeah.
And maybe the two of you would like to briefly discuss. Matteo, you want to start?
Yeah, it's very, very complex because you have the majority of paper. Well, I spent some time on that because I thought that I could find the answer that says there is much more collagen 1 than collagen 3 in varicose veins. There's just one paper, I can't remember actually the author, that said the opposite. Much more collagen 3 and collagen 1. But what is interesting, I mean, at the beginning I went, okay, I'm sure I will find an answer in varicose veins, but actually here we are not talking about varicose veins. Yeah. I mean, so it's something else that interferes with the normal compliance of vessel. That's why I switched to the bladder. That's completely different. I mean, they've studied specifically the detrusor muscle, and here you see this one, and the patient cannot relaxate properly. And that's very interesting. If you look at the bovine bladder, you really see that the collagen 3 goes down with development and the collagen 1 goes up without any other thing. But, I mean, unfortunately, varicose vein was not the answer.
So in the first group of patients that you got that had the restenosis,
yeah.
Obviously you were sampling above, and we found this. You did not sample below the area which you might think would be not... Yeah,
we have sampled the wall length of the vessel, and we have seen exactly the same alteration. But our problem was that some nasty but intelligent reviewer could ask, you've dilated the vein, and so that's why that's why I showed you the results in the more distal part. But this is the pattern of the whole length of the lesion that Paolo gave us.
So to conclude maybe this little brief interlude, Paolo, why don't you tell us what you think is going on with the change? You think that this is just the vessel trying to respond to become larger and therefore in some way...
I think the two possibility can be focal change in molecular expression due to malformation. And this can be a possibility, or also the reduced blood flow may remodel in type 3 collagen cells. But the interesting thing for interventionalists is that type 3 collagen is very, very low extensibility respect to type 1. So sometimes you may see a big waste, and this is due to the impossibility to dilate more vein because you do not have a little extensibility because type 3 collagen is very resistant to this. And the other comment is that several negative opinion papers were published in neurological journal asked for autoimmune reaction in the jugular vein as a product of MS rather than a primary mechanism. And really, the study of Cohen showed clearly that there are no T cell at all and not macrophage infiltration. So it seems to be really two different things.
I really have normal veins, but abnormally composed.
Yeah. Well, I could talk a lot longer, but I think we have to move on.
Thank you very much.
Thank you very much.
Thank you.
So now we're going to start with the 5-minute presentations, the abstracts that were submitted. And Paolo, you want to start?
Yes. First one is Ken Mandato with quality of life changes after endovascular treatment for CHSVI patients with multiple sclerosis.
First off, I want to thank the Society for allowing me to present today at this very important topic. Interestingly enough, 3 years ago, before our group in Albany knew very little about this, when word of mouth came out, we did what everyone else did, and that is Google some very specific terminology, and we gained a very large interest in this and made connections from there. Fast forward 1,500 to almost 2,000 patients later, and some more connections with our friends in Ontario and other parts of the Great White North, as well as throughout North America and Europe. I have no regrets. This has been pretty impressive. So getting to the first abstract, the study purpose was essentially to evaluate the short-term outcomes after endovascular treatment. So what did we do? We did a retrospective study over a 4-month period, and we used the MSQOL-54 survey. 14 scored components, resulting in composite scores in both physical and mental aspects of health. Pre- and post-question treatment questionnaires were assessed, and the changes in the quality of life and MS subtype were studied. Now, we all know about the MSQOL-54. The main salient features include both physical and mental components. I won't read through all of them, but these are the most salient features. So what did we find? There were 213 patients treated in this time period, and we had a 90% response rate, which is pretty impressive because the document is one long in and of itself. And, patients who may have not have tended to do so well may not have felt like they wanted to fill it out, but it's a big testimony of MS patients who really, really want to make this go forward fast and hard so we can help as many people as we can. And I think that's tremendous to get such a high response rate. The mean age we looked at was in the high 40s and two-thirds female to one-third male. The predominant subtype was relapsing remitting, followed by secondary and then primary progressive. So what did we do? 189 patients underwent angioplasty alone, and we looked at 2 different aspects of this study. Indications for angioplasty were greater than 50% stenosis, and as we've alluded to through various talks during the week, we also treated patients on the basis of a less than 50% with all the things we talked about with webs and reflux, flow hesitation, collaterals, that kind of thing. Typical angioplasty result, moderate to high-grade stenosis. Yes, these are static images. They don't give you the real, true appreciation of reflux, but you can only imagine when you have such a tight stenosis and the flow is going in a retrograde fashion and what it could possibly look like when you do the angioplasty at the base. 3 patients in this study underwent angioplasty with stent placement due to diminished flow after angioplasty. I don't think the purpose of this abstract is to talk about the merits of whether one should have done angioplasty or not. We could talk about extrinsic compression and omohyoid muscles and all that. Nonetheless, I did want to show a typical case of where angioplasty did not go perfectly as well as we would have liked over a multi-segment internal jugular vein, but the patient wound up doing very well with stent placement. So the study results. In 192 patients, the mean composite physical health score improved almost 9 points. And in the mental health composite score improved about 8 points. And we try to figure out, based on the previous neurologic literature, what's a significant result. And we had to dig and dig, but you look at a lot of different studies that compare quality of life with depression, with bladder spasms. There's a lot of papers out there of very different symptoms, and it came to the conclusion that approximately 5.2 to 5.5 was a significant number in multiple different parts of that MSQOL scoring system. So that's very significant right there. The physical health composite score improvement seemed to be most in the relapsing, remittings, and primary progressives. It doesn't seem like a large surprise, but not a terribly large drop-off in the secondary progressive population. And I was mentioning to somebody before that, even patients who are chronically wheelchair-bound with high EDSF scores, some people might say, well, because they didn't get up and walk or run a marathon, the naysayers may say, well, that's not very significant. However, I have a million anecdotal stories of a patient who had multiple hospital admissions due to cellulitis under their arm due to contraction, and then after we treated the patient, free mobility of the arms prevented them from having any more need for antibiotics because of lack of cellulitis. And that to me is absolute tremendous victory, and I do it all over again. And again, same kind of percentages with the relapsings and the primaries versus the secondary progressive. The one other thing we looked at in the study was the physical and mental health scores based on the year of diagnosis of MS to begin with. Now this is a little tricky because, as you know, when you talk to patients, they'll say, well, I was diagnosed in X year, but 30 years before that, I remember having visual changes, or I was falling down, I was dizzy. And so it's really hard to really quantify this data perfectly, but roughly speaking, within 10 years of diagnosis, there was a significant improvement in patients in the 70 to 80% category with a little drop-off after 10 years. And the same thing with the mental health score. So in conclusion, clearly, endovascular treatment of CCSVI can produce significant short-term improvement in both physical and mental health scores and quality of life. It occurred less often in patients with secondary progressive when compared with relapsing, remitting, and primary progressive. And the frequency, as I said, was more so in patients diagnosed less than 10 years. And while this data is encouraging, of course, we always recommend a prospective randomized trial to validate these results and the durability of the results. And these studies are clearly coming, because this is the end point. It's making patients better, and that's what makes us all feel better. I have another. Okay.
So Ken has one more abstract to present, and then we'll take questions for Ken.
All right, the second study is evaluating the role of Doppler ultrasound in the diagnosis of CCSVI, and we looked at it from a few different angles as well. Now, I just want you to stare at this picture. You know inside your head whether you look at this glass one way or the other. Now, of course, I look at it half full, and I would think everybody in this room looks at this glass as half full as well, or you probably wouldn't be here right now. My study purpose, and I'll come back to that, my study purpose is to evaluate the ability of ultrasound to diagnose CCSVI in patients with multiple sclerosis. What did we do? Retrospective study of 310 patients over an 8-month period using the standard Zamboni protocol within 24 hours of performing venography. I don't think we need to go through all this. Everyone knows the criteria and what we use and what we look at. Now, very briefly, I'm not going to talk about all the corroborative studies because pretty much everyone's here in the room and they know what they did. But the one thing to mention about this is that most of the studies do not necessarily have venographic correlation with ultrasound. Few do, but it's just something to think about when we're trying to gather data. And on the flip side, when we want to talk about supportive evidence, I think it's only fair and balanced on some level that we talk about the literature that's out there with a grain of salt that says that these are not supportive studies. And so that's something that we just wanted to take a look at to be fair when we came to our conclusions. So what are the results of our study? Again, 310 patients over 8 months. We defined a few different things. Again, like I said in the last abstract, a positive venogram of over 50%. That was the first arm of the study. The second arm of the study was less than 50%, and looking at all the other things, including the reflux, the membranes, the collateral vessels, the reflux, and flow hesitation in general. So we all know that there's the many phases of internal jugular vein insufficiency. There's greater than 50% tight stenoses. And then there's, again, a static image on the right side, which showed massive flow hesitation, reflux, not necessarily a major stenosis, although if IVUS was performed, that might be a little bit different. But we're not comparing IVUS in this study. So we found that most patients did have a positive ultrasound, and about 70% of those patients, not 100, but 70% of those patients have a positive venogram, and that was the first arm of greater than 50%. Now, what we did also find is that the 28% of patients that had a negative ultrasound, we did find some positive findings on the venogram. And this was, basically in the false arm of the study, and that's why we came to a conclusion based on that there was a false negative rate when we saw 0 or 1 criteria out of 5. And the ROC curve based on that pretty much showed the data right up the middle, where we couldn't put things into true positive or true correlation. We moved on to the second arm of the study, which we talked about the less than 50% stenosis. And again, we saw the 72% positive ultrasound. And 97% of those patients we correlated with the venography and underwent angioplasty of at least 1 vessel. So the sensitivity went up when we clearly felt that venography was more sensitive when we didn't use 50% as a marker. Unfortunately, of the remaining 86 patients with a negative ultrasound, again, with our sensitivity going up for venography, we did have those people more in a treatment arm. And so the false negative rate was pretty high. A very similar ROC curve comparing the two modalities. Very briefly, there were a few other variables not to exclude from our study, and that was when we used the extracranial sonography first to remove the second component, the deep cerebral veins, and pretty much had similar results. Then we independently looked at the right and left internal jugular veins, which also yielded similar results. We just try to look at this at many different angles to try and come up with any data possible. So, as I mentioned, a lot of the corroborative evidence in the past much of it did not have venographic correlation, and we think that's important going forward with any prospective studies to really put them all together and try and come to something. Additional studies did fail to replicate results, and again, we can look at that in many different ways, but there could be motivational, technical factors, and that really needs to be important when people are trained in a certain manner to perform the very specific Zamboni protocol before you could come to those conclusions. Now, some of those people have come to the conclusion that CCSVI is not a true entity. Albany, New York, and everything that we're doing is the exact opposite. We do not suggest that CCSVI isn't a true entity. Ultrasound has an amazing correlation, particularly when venography was positive. We always traditionally looked at venography and arteriography as the gold standards. That might need to be changed. This is a different entity than we've seen in the past. Just like 50% stenosis was always a traditional marker, we need to look at that differently as well. But the utility of any non-invasive examination with potential significant false negatives really needs to be looked at very closely, because the purpose of an effective diagnostic test is to determine the utility of the next step. Based on that, we don't want to necessarily exclude patients from conventional venography based on pre-procedure ultrasound findings that may have shown 0 or 1 or 2 criteria. And again, I could speak anecdotally of a lot of people who have gotten better where we personally just didn't see a lot on ultrasound. Not IVUS, just regular ultrasound. So we're advocating, at least at the present time, that no stones left unturned until we could get more data out there correlating ultrasound and venography that much closely. And also, I think using the 50% is going to exclude patients from treatment. If people are just starting out with venography and they don't necessarily see that big diameter change at the base towards the valve, they might exclude patients from treatment. This happened to us when we first started, when it was a big learning curve, and I had patients come back who I wound up treating retrospectively who have done just absolutely amazingly well. Now, the one thing I think is huge with ultrasound, and I tell patients this after we already treated them, is that change is the ability to evaluate 2 points on a line. I kind of made that up while I was talking to a patient, and I said this. We definitely want to get ultrasound follow-up, and I think it's very important, especially when done in a very reputable institution, because I'll get patient emails saying, I did great for 9 months, I'm kind of regressing right now. I look at the ultrasound very specifically. What did it look like right after we treated? What did it look like at 3 months, at 6 months? And what did it look like when you started your decline? So now I can more specifically look at the criteria based on that, considering that we already made a change based on angioplasty. And I think that's extremely important to do. And of course, prospective blind and randomized controlled studies are necessary to test the validity and durability of these results. Because in the end, this is what it's all about. I feel like my life in medicine is I live for this. I get an email, I mean, you could read through it. I'm not going to read this verbatim, but someone who could barely even walk before, on the bottom quote there, now he wants to know if he can snowboard again. He went from walking with a cane to walking, and now he wants to do black diamonds on a snowboard now that he has his balance and vision back. I can't see what's better than that. That's why I do this, and I appreciate your time.
Okay, well, I guess maybe 2 quick questions. Okay, Robert.
Congratulations for your work. I quite did not understand really how you did this. I mean, those 84 patients of 113 that had something on venography, can you give us insight what they had? What did you find on catheter venography?
Well, I mean, it depends. We're talking about the first arm that was over the 50%.
No, I'm just saying
86
those
patients who were negative ultrasound went
negative
on,
ultrasound.
and 85 of them had angioplasty.
Yeah.
He wants to know what did you see in general in those 85?
There's going to be, I can't give you the specific number on all 85, but I will tell you the majority of them did not have greater than 50% stenosis. They had either what we appeared to be a hypertrophic valve, or when we carried out the venogram during a prolonged venogram, we can see flow hesitation, stasis reflux, and all that.
But it's, in my opinion, it's not a fair comparison because, you know, the criteria have been established to say who is at greater risk to have a venous hemodynamic change. Now, the fact that you find something, you know, on catheter venography, yes, we agree, we all agree with that, but that does not mean, at least in my opinion, that this person has a hemodynamic condition that necessitates to be treated. You understand what I'm saying? Because, for example, that patient may have only the deep cerebral vein reflux, so what? He's not, I mean, he has something wrong, but still he does not match the criteria.
Right, I guess then the follow-up with study view would take those 85 patients that we saw negative ultrasound, that we treated those jugular veins, and specifically evaluate those patients for quality of life changes to say whether there was a significant change functionally, physically, mentally. I mean, I think that's what you're saying, is it didn't go a step far enough to come to that conclusion. Because if we saw that the majority of those patients did not improve, then you're right. Then just because we saw something there and we ballooned it doesn't necessarily mean that that was the primary problem.
Last question.
Yeah, that was actually my question. In that group, did you look at specific outcomes in that group that did not have 50% stenosis but flow abnormalities? Because if you can show that they also do benefit, then you have to argue what's the best test. But if you show that there was less of an improvement in that group, that makes your overall outcome for the group that had 50% stenosis even more impressive. Maybe you should just select the patients. So I think it would be great if you guys sort that one out.
That'll be my next abstract at the next conference.
Great. Okay, thanks, Ken. We'll move on. Paulo?
Yes. And now, Dr. Mamoun Al-Omari from Jordan, internal jugular vein valve morphology in patients with CCSVI, angiographic findings and schematic demonstrations. Please, Mamoun.
And are you hearing me? Is it working? Okay. My subject will be about the jugular vein morphology in patient with CCSVI based on angiographic findings, and will give some schematic demonstration to simplify this complex morphology. No disclosures. The objectives is to give a proposed angiographic classification of valve morphology in patients with CCSVI, and to simplify this complex morphology by schematic demonstrations. As you all know, the CCSVI is a condition, probably a syndrome, described in a MS patient characterized by abnormal venous hemodynamics in the jugular vein and the azygos vein. And the jugular vein is the most common vein affected. Most of these abnormality in the jugular vein are located at the level of the valve. Most, but not all. Materials and methods, we retrospectively analyze 556 jugular venograms in 278 MS patients. All of these patients have positive criteria for CCSVI by Doppler ultrasound before angiography. However, the classification was based mainly on the angiographic findings. This is the normal jugular vein. It looks like there is usually dilatation just above the valve, and then you see free drainage from the neck down to the chest. And this is the demonstration of the valve morphology. You have two leaflets, and they become very close to the wall to allow venous drainage from the neck down to the heart. In CCSVI patient, the valve is usually malformed and compromised venous drainage. We consider the valve abnormal if it's associated with first poor venous drainage or reflux or outflow through collaterals, and we assume that small distance between the valve leaflets is also abnormal. This is our proposed classification for these venographic findings. The first type is jugular valve stenosis without severe structural abnormalities, and the second is abnormal valve leaflets. The third is septum or membranous obstruction, and the fourth type is severely malformed valve. And I just show you some pictures of all of these types. The jugular valve stenosis without severe structural abnormalities, we have annulus, fused leaflet, and transverse leaflets. Can I get this? Is it working? Yeah, the annulus is a circumferential stenosis of the wall of the valve. It's focal circumferential stenosis, and it looks. This is our demonstration or proposed demonstration of the annulus, and it looks on venogram as focal annular thickening with long-lasting reflux. Fused leaflet means that the leaflets are in normal position and they are in normal size and shape. However, they look stick to each other, causing severe stenosis. Like in this case, you can see stenosis of the valve, which grossly normal but stenotic, and you can see the flow through the collateral veins. Transverse leaflets mean one or both leaflets are in transverse position inside the venous lumen. It's not working this way. Okay, here you can see nicely the transverse leaflet inside the lumen. One leaflet is in transverse position, and in this case, both leaflets are in transverse position. Abnormal valve leaflets, we have accessory leaflets, ectopic leaflets, and long leaflets. This is just demonstration of the accessory leaflet, 3 leaflets, one in the reverse direction, This is easily seen by a Doppler ultrasound and sometimes difficult to appreciate on venography, but you can see the indentation, multiple indentation on the balloon during angioplasty. Long leaflets mean that the leaflets are two leaflets, but they are elongated and stuck to each other. So there is stenosis, but the leaflet itself is elongated. Sometimes you can see tapered narrowing, as in this case, and sometimes non-tapered narrowing, as in the case on the right-hand side. Ectopic leaflets mean one of the leaflets is in ectopic position. Here one leaflet is on the same side of the jugular wall. This is good for the axillary vein, as Paolo Zamboni mentioned before, but it's not good for the jugular vein. And you can see here another type. Septum, I think all of you are aware of the septum, easily seen on Doppler ultrasound, and on venography it's seen as a filling defect inside the lumen of the jugular vein. Membrane, it's sometimes very difficult to appreciate the membrane on venography if you do not suspect on ultrasound. This is a demonstration of a membrane here at the level of J1, and it is another membrane. Severely malformed valve, we have inverted valve, sigmoid valve, and double valve. Inverted valve, like this, both leaflets are in a reverse direction, as in this case. And you can see this on venography. There is complete obstruction of the vein. The blood is going down, up, and that nothing is going down to the chest. This is good for femoral vein, but it's very bad for the jugular vein. Sigmoid valve means that the valve is elongated and tortuous, as in this case, and this is our proposed schematic demonstration of such a valve. Double valves, not very uncommon to see it. You can see two stenotic valves at the lower internal jugular vein, and this is our proposed demonstration of such a valve. Conclusion, jugular valves play a vital role in the pathophysiology of CCSVI. The valve morphology is highly variable. The commonest are annulus and septum, and all pathological valves in CCSVI patients are associated with altered venous hemodynamics. Thanks for attention, and thanks for the organizing committee.
Very nice. Questions from Amun about the spectrum of all sorts of valve abnormalities? Adnan?
Quick question. How often do you see valves absent?
Absent valve without with CCSVI or without CCSVI? You mean? I think if the valve is absent, there should be another pathology like septum or membrane. But no valve, I haven't seen. There is no valve in such patient. If there is hemodynamic abnormality, you always see something abnormal within the lumen, or is it a septum or malformed valve or a membrane. But you can see sometimes a membrane without a valve. I have seen cases with membrane which must be a malformed valve.
I just wanted to make the point that sometimes you don't see a valve because the valve is working fairly normally. You see rapid outflow, and it's not that you can't see it. So I think that's the category where you have normal valves. But I just wanted to comment on excellent work. I think that's really very nice correlation between what we suspect is going on.
Thank you.
Thank you very much.
Thank you for the excellent presentation. And the next presentation is by Dr. Zhang, the cerebral perfusion pattern of patients with multiple sclerosis, MS using MRI.
I'd like to first start off by saying thank you to everyone at the ISNVD for accepting this work and allowing me time to present what our group has done. I'm David Utrainen. I'm here on behalf of Shang-Yi, and I'll be talking about the average perfusion in the brain for patients with multiple sclerosis. So we've taken two different groups here. We have 140 clinically definite MS patients The mean age was 48 years old, and they were all imaged on a 3T Siemens MRI system at the Applied fMRI Institute in California under a comprehensive CCSVI protocol. We've also collected data on 26 normal controls. Their mean age was 38 years old, and they were also imaged on a 3T Siemens MRI system, and they were imaged for the comparison at the Wayne State University. All right, so from that comprehensive protocol, I've taken 3 different sequences that I'll be talking about. The first is the 2D time of flight MRV. We use this to determine cross-sectional areas in the internal jugular veins, and this was done because it's actually acquired with high resolution. So based on these results, we separated the MS population into stenotic and non-stenotic. So stenotic being those patients who have abnormalities or narrowings in the jugular veins. The non-stenotic, we did not identify that. The 3D FLAIR for brain volume, and the 2D phase contrast MRI. We collected 2 slices that we included, and they were both collected at a VANC of 50 centimeter per second, the first at C2 level and the second at the C6 level. So to explain how we did brain segmentation to determine the brain volume, first we did skull stripping, and you can see the original data in A. This is a sagittally acquired 3D FLAIR sequence. B, C, and D show the segmented brain volume. So the signals that are left include the cerebrum, cerebellum, brainstem, including the pons, as well as the ventricular system. We use this total brain volume in the calculation. I'll show you in a moment. Here we have our phase contrast flow slices. At the time of flight MRV sagittal projection, you can see the localization. The first C2, I have the ROIs drawn, or the regions of interest for the internal carotid artery on both right and left, and the vertebral artery on both right and left. We summed this flow to determine the total arterial flow to the brain. We did not include the external carotid artery, since most of this goes to superficial tissues of the face. We also collected the data at the C6 level so that we could measure the internal jugular vein flow. And again, you can see the regions of interest are drawn here on the magnitude and phase images. And we thought it would be interesting to compare the internal jugular vein flow to this average cerebral blood flow measurement, since it has been previously reported that the cerebral blood flow may be reduced in multiple sclerosis patients. So here are our results. This shows the average CBF measurement, milliliter per minute per 100 gram of tissue, as a function of the internal jugular vein flow. And what we see here is a very large distribution. The orange and the red icons, these are showing the stenotic group for the MS. The blue, we have the non-stenotic MS. And our green icons, this shows the normal control group. Also, for each one of these individual groups separated by age, above 50 years old and below 50 years old, we have the linear regression plotted. So what I note from this, mostly, is that I see a very clear separation based on the internal jugular vein flow rate at around 7 milliliter per second. On the lower value, we do have most of our stenotic MS patients. There's a few that are over 50, there's a few that are under 50 years old. And on the other side, we have the remainder of the stenotic MS group, but all of the non-stenotic MS and the normal control group. We do see a positive correlation between the internal jugular vein flow rate and the average CBF as calculated. The strongest correlation is seen with the non-stenotic MS group. So what conclusions can we make from this so far? Well, the IJV flow appears to be a potential biomarker for stenotic MS patients. In all the groups, the CBF and IJV show a positive correlation. The strongest correlation is observed in the non-stenotic MS group. And age and MS type were not significant predictors of relative CBF or average CBF. Our future research directions, we want to reevaluate the average perfusion by removing the CSF signals. This may play in a fact that some of the patients may have atrophy of the brain, and we've included the ventricular system in the current measurements. We want to do a more in-depth analysis of the sources of error that may mimic this apparent linear behavior we're observing, this positive correlation between the groups. And we want to do a comparison of this approach with a full high-resolution PWI approach, and using the latter to estimate average CDF. Thank you.
Questions?
So I'm curious to know how you calculated the 3D, the brain volume from 3D FLAIR image. I mean, how you separated the CSF from the tissue?
Well, we actually did not separate the CSF from the tissue.
You said that you calculated the brain volume, that 3D FLAIR was used for calculation of brain volume.
Yes, the 3D FLAIR was used to calculate brain volume. To use the moment of inertia to detect the edge quality, and thresholding was applied to isolate the brain signals. What we included in the volume, however, was the cerebellum, cerebrum, and the ventricular system. So the CSF signals were included in this measurement.
I really don't understand. Because nobody in the world does use 3D FLAIR for calculation of the brain volume, but uses 3D T1. Moreover, when you try to threshold or whatever algorithm you are using, because of the signal intensity of the lesions in MS patients, they are becoming part of the CSF. So now everybody in the world uses so-called in-painting techniques to put back the lesions to the tissue. If not, you are going to have change of the brain volume just because you are segmenting lesions as being CSF. I don't know if you understand what I'm saying, but basically, you should use the 3D T1, and B, you should in-paint the lesions.
Thank you, Robert. I'll address that a little bit. Actually, he did not segment out lesions or CSF yet. That's what he was trying to say. That's just the complete brain volume. And what he wants to do is, in fact, exactly what you were suggesting. And obviously, David, having 3D T1 and 3D FLAIR would be a good thing to validate that if you're just skull stripping and looking for total volume, that you essentially get the same answer. And the final comment I would make is, even if we don't normalize that to brain volume and we simply plot the arterial flow versus the IJV, so there's no normalization, it has the same trends that he showed here, even without that.
Great, thank you, Mark. Let's move on. Thank you, David.
Next presentation is enhanced imaging of simultaneous stuff. Dr. A?
I think it's Dr. Fang. Yes, yes.
Dr.
It's this one.
Okay. Okay. Okay, Dr. Zane, the cerebral perfusion pattern of patient.
No. Okay, missed one, yeah. So the next one is Dr. Fang. Flow through the internal jugular vein is reduced for multiple sclerosis patients with decreased compared to those without observed on MRI.
I'm sorry,
That's not it either.
No, that's right. I'm sorry. That title was the complete title. What I'm showing here is a shortened title. Hopefully, it's going to be easier to read. Basically, what I'm going to show is flow through internal jugular veins for MS patients is reduced, and I want to give a shout out to Dr. David Hubbard for sharing the data with us. Without the data, we can do nothing. So, you probably have heard a lot. Dr. Hickey has given a talk on 300 MS patients yesterday, and you have seen others like Dr. Benson using the flow data as well. So what I'm going to show you is going to be a little background on this, how we do the flow quantification, and hopefully it's definitely much easier than what the doctors do. So basically what we do is we collected the phase contrast images at the C6 level below the bifurcation of the common carotid artery, and we basically evaluated the flow. So this is the software, a screenshot of the software that we use, and I wrote this software. So basically you can draw the contours for all the vessels, and a click of a button you get the flow. And for one slice, one case, you get, it's about 5 to 10 minutes. Depends on, sometimes if you're not sure which vessel is which one, you have to check with the 3D MRA to make sure you're using the correct name. And after you do this, so we as you can see, we have all the vessels, almost all the vessels segmented. However, in this case, in this report, we're only reporting the IJV flow normalized by the total arterial flow. The four red contours are the the common carotid artery and the vertebral artery, and the two blue ones are the internal jugular veins. So we get that for this case, and we do it for basically all the cases that we get from either Dr. Hubbard or other sites that collaborated with us. So here I'm just showing you a screenshot of some cases that we have done. So basically what I'm going to show you here is going to be 217 cases, MS cases, all from Dr. Hubbard's site. And I'm also going to show you 15 normals here. So once we have done process each individual cases, I have another software. Basically, we organize all the data in one server. So I have another software basically reads the server, and you can basically do any analysis on any group of cases. So I can do statistical analysis. I can plot. As you have seen, the other flow plots is all came from here. So it's comprehensive, it's versatile, and because I program it, so it's very very flexible. It's also standardized. So here I'm showing you some of the example flows that you have seen probably several times. Now, for this case, for this study, I'm just going to show you the total arterial flow. Here I'm plotting the left and right common carotid artery flows, and for the left and right vertebral artery flows. As you can see, first of all, the solid triangular black symbols are the stenotic MS patients. These are the patients with a stenotic appearing IJV. The open triangles, rectangles are those without a abnormal appearing IJV, but they may be stenotic. Well, they're not stenotic in terms of anatomical assessment, and the green ones are the normal cases. Basically, what we have found is, if you look at the total arterial flow, there's no difference, absolutely no difference between the normals. I'm not showing the normals because we only have 15 normals, so I didn't do that. There's no difference between the non-stenotic cases and the MS patients with the stenosis at the C2 level, and there's no difference between the MS patients with stenosis at C2 level compared to those with the stenosis at C6 level as well. So there's basically no difference among all the MS patients in terms of total arterial flow, which is reasonable. Now, so here I'm going to show you the last one. Basically, it's going to be the flow result that coming from these 217 MS patients. First of all, these are the normals, 15 normals. So on the horizontal axis, you're seeing the dominant jugular vein. On the vertical axis, you are seeing the subdominant jugular vein, meaning the jugular vein with less flow. So you can see the normals are nice. They're basically all sitting above the 50% mark, which is normalized by the total arterial flow. Now, so the green symbols here I'm showing is the MS patients with non-stenotic appearing jugular veins assessed by MRA. And you can see they are kind of mingled with the normals here. Here I'm showing the MS patients who has C2 stenosis. Basically, they are stenotic at the C2 level, upper neck level. And I did a comparison between this group and the non-stenotic group. The p-value is less than 0.001, meaning the IJV flow is significantly reduced. And the last group is the stenotic group at the C6 level. I also did a comparison using this with of this group with the C2 stenotic group. Now, even between these two stenotic groups, the difference between their IJV flows are significant. And if you, I mean, it's getting a little crowded here, but if you look at the stenotic cases at the C6 level, they're definitely far apart from the normals that you can see. The very few normals we have. So the conclusion here is that we have developed abilities to quickly process the large number of data sets, and we can perform the statistical analysis comparisons. And the total IJV flow for MS patients are definitely reduced for those with a abnormal appearing anatomy, basically stenosis. Here I want to emphasize one more point, is that we definitely need more normal controls in order to establish a normal range for comparison, and that is very important. Okay, thank you very much.
So thinking from a clinical standpoint, one thing when I look at scatter plots like that is, how are you ever going to come up with sensitivity and specificity that would be potentially clinically relevant? I mean, even, I don't know if you matched your age and sex and everything. I wasn't sure if that was shown, but even if you did so, it's a scatter plot. And yes, I see the trend. That definitely the reds are the lowest, and the blues are in the middle, and the greens are up top. But they're all over the place. And so how do you develop a valid test that could be used in the clinic? Because you need a lot more sensitivity and specificity before it really becomes clinically relevant.
That is a good point. However, in here, I think what we have done is basically, as you said whether they're age and sex match. First of all, we really don't have too many normal controls to do a full strength comparison. And so that's kind of one of the difficulties that we're facing, and hopefully with the society growing, and we can get more normal data. Now, in terms of pardon me?
Were they age and sex matched or not?
You mean the?
Health controls for them.
No, I think first of all, we only have 15 in here. I don't think it's age and sex matched. They are recruited basically at our site, and I don't think it's matched.
Okay, I think we're going to have to move right ahead. Thanks, Dr. Feng.
Thank you.
Now, Dr. Carmen is substituted by Adam
okay.
Siddiqui, intravascular ultrasound for detection of a valgus and internal jugular vein abnormalities as part of a premised prospective randomized endovascular therapy in multiple sclerosis study.
Firstly, this is a talk that was prepared by Yuval Carmon, who's our endovascular and multiple sclerosis joint fellow. Unfortunately, or fortunately for him, he's a new father, and so he could not break away from his wife and young child. My disclosures, as listed here, none are relevant to the topic under discussion. I will forego the introduction. We all certainly know why we're here looking at CCSVI and MS, and it's been investigated by Dopplers, but we also understand, despite the contentions that were made earlier, that venography is the gold standard. It's not quite clear if it really is. For those of us who certainly appreciate intravascular ultrasound, it appears that there may be a role for utilizing Doppler technology from the inside, and there are no studies reporting that. So as part of our premise trial, which is a prospective randomized double-blinded trial, we enrolled patients with relapsing remitting MS with EDSS scores which were relatively limited, which fulfilled at least two criteria of CCSVI. 10 patients were enrolled in the open label phase, and to date 19 patients have been enrolled in the second phase, which is a double-blinded randomized trial, so we're one patient away from being done. And the methods involved cathetervenography of the azygos, right and left IJ in that order. And IVUS initially was performed only when we suspected stenosis for the first 10 patients, and then for the next 19, we have performed IVUS throughout the entire segment, the IJ from the diaphragmatic attachment up to the superior vena cava, and from the skull base to the subclavian for the jugular veins. We looked at IVUS parameters, including the presence of intraluminal defects. We categorized these post hoc because we weren't quite sure exactly what we were going to see. and we have so far divided them into septi, multi-channel veins, interluminal hyperechoic filling defects, double and parallel lumens, abdominally thickened vein wall, as well as presence of reduced pulsatility. And these results are being prepared for submission right now. But what was most interesting in our point of view was the azagus was clearly the leader as far as intravascular abnormalities are concerned. We detected them in 88%, or the vast majority of our patients where we actually performed the IVUS. Pulsatility was reduced in about 40%, and stenosis itself, which we define as less than 50%, whether it's correct or not remains to be seen, in about 55%. The left IJV was the second most commonly affected vein in our cohort, where interluminal defects were identified in about a third of patients. Reduced pulsatility was the most prominent abnormality in about 2/3 of patients, and stenosis was identified in about a third of patients. All patients who had stenosis by IVUS also demonstrated interluminal defects. The same thing was very true for the azagus, where all stenoses were identified, so there was a 100% correlation as far as stenosis is concerned on IVUS and angiography. The right IJV, we found interluminal abnormalities least. They're about 20%. Reduced pulsatility, again, was the most common abnormality detected in about half the patients, and stenosis was found least in about 25% of patients. These are some examples that I had shared yesterday. I will not forego with the videos, but again, the outer hyperechoic part is the wall of the vein, and this inner chamber is this hyperechoic material that lines the wall. Whether it's organized thrombus or thickened membrane or thickened wall, it's not quite clear, but this is certainly what we're seeing. And we're seeing within these areas channels that seem to be abnormal. Stenosis, we are rather rigorous in terms of our definition of stenosis. For IVUS, for stenosis to be noted, we wanted the vein to be completely collapsed around this 1 millimeter probe. And so our stenosis was more apparent on venography than on IVUS because of the different definitions, and we have not performed based on diameter alone. We certainly have that ability to use the 50% mark, but for IVUS, this was what we categorize as stenosis, where the probe is being hugged by both vein walls. And again, in this case, you can see the heterogeneous signal which surrounds the probe. And here's an example of a double lumen, whether you call it membrane or septa. Certainly we have no consensus on terminology. So conclusions here are that we were able to show an extremely high rate of intravascular abnormalities within the azagus vein. The azagus vein, in our experience, was the most commonly affected vein for these patients. That's certainly not been reported by most people. Similar abnormalities were found in the jugulars, both on the left and on the right, but to a lower rate. And similarly, stenosis was also found most commonly in the azagus and less so in the jugulars. But again, our definition there was about 50%. We feel that IVUS certainly provides significant diagnostic advantages over the gold standard in detecting specifically these intraluminal abnormalities, which we believe are quite consistent with the underlying hypothesis of venous congestion, probably cyclical thrombosis and recanalization that we believe characterizes CCSVI. Thank you very much.
Questions? Yes, Maman.
A great presentation. What's your definition for annulus? And you consider it by IVUS as intraluminal or extraluminal?
So in our experience, annulus is almost most commonly noted in the region of the valve. It appears to be a fibrotic thickening of the entire wall. It certainly could be fused valves, which is something that Sal has suggested and you suggested as well. And that may actually be what we are all calling annulus, because there's no really extrinsic thickening of the wall per se in that region. Some walls are thickened, but particularly in the region of the valve, there seems to be a particular fusion, and I suspect those are fused valves.
Marion?
It's interesting that the prevalence of the IBUS visible lesions in jugular veins is much lower. It's even lower than that of these problems revealed by means of standard venography. So perhaps many of these abnormalities are not intraluminal in this territory, but rather extraluminal. What's your thinking about it?
So the way I'm interpreting this is that, one, the way we defined our stenosis, as I mentioned to you, was rather rigorous. We had a different definition because IVUS was interpreted completely blinded in a separate fashion than cathetervenography. We did not do multimodality correlations as to this point. So that explains one aspect. The second aspect is that reflux forms a major component of abnormalities detected by cathetervenography. And there's no currently possible way to really detect flow direction through IVUS. And that also, if you included reflux along with these, I think there's a close correlation.
Okay, but anyway, it seems that the azygos territory, these are the intraluminal stenotic problem, and in jugular, mostly refluxing, at least half of this patient.
Yes.
Okay, quick final question, Sal.
And then among a group of us that were talking about IVUS and looking at your cases yesterday, we were a little startled by the interpretation of thrombus within the vessel. And my own suspicion is that it's going to be difficult to differentiate very slow flow from thrombus. And when you get back in the saddle, I would suggest trying to do some aspiration to try to prove that that's thrombus, because we're interpreting it differently.
Yeah, so very good point. I actually have very clear examples of stasis, because the stasis appears very, very differently than the crysenteric hyperechoic shadows. There's no physically plausible way for slow flow to layer out in this crysenteric fashion compared to when there's actually stasis. So I have very good examples of actually fluid blood levels and contrast blood levels which do prove what we're looking at is tissue of some kind. Now I'm calling it thrombus, but I don't know that for a fact. I have no way of knowing that. I'm just saying it's a hyperdense tissue material which is endoluminal.
Thank you, Adnan. Let's move on. Staying in the azygos, I think, right?
Yes. Dr. Tai, measurement of azygos vein blood flow in patients with multiple sclerosis using MRI.
Thank you, Dr. Zamboni. Aisha Tai actually couldn't be here, so I'll be presenting on her behalf. My name is Paco Kenny. And yeah, that last presentation is actually a great lead-in to what I'm going to be talking about. We did a study that we measured azygos vein blood flow and vessel area, and we were able to compare MS patients and controls in these measurements. We got 105 patients with clinically defined MS and 23 healthy controls. We scanned the patients at one site, and the healthy controls were scanned at a different site at Wayne State. We were able to divide the patients according to their type of MS. We had that information. They were scanned using a velocity-encoded phase contrast MRI at 2 different levels. And the upper level was around the T5 to T6 vertebrae area, and the lower level was around the T7 to T8. Wei Feng, who presented earlier, showed you his software that he created where we were able to quantify the flow with the phase, and you can see the magnitude image here and the phase image here. We draw these contours, and we're able to use the phase information within the contour to show flow, or to quantify flow. We created some histograms, we calculated mean and standard deviation, and performed some t-tests to see if we could get any significant difference between MS patients and controls in these measures. Starting with results for the azygos upper level flow, you can see histograms here for the MS patients and controls, and the means and standard deviation below them. The mean in the MS patients was a little bit higher, but it was not significantly different. We only had 23 controls, so you don't see much of a unique distribution here. But once again, the means were not significantly different. Lower level, we pretty much see the same thing here, kind of a Gaussian-looking distribution in the lower level and upper level flows, but we don't really see a unique distribution in the controls. And once again, the means are not significantly different after performing the t-test. With area, we kind of see something interesting in these histograms. The left tail of the MS patients, we see these smaller areas. We're seeing a narrowing of the azygos vein, and we do not see that in the controls. So we see this narrowing, and we do not see any significant difference in the means, but the histograms are interesting. And maybe once we get more controls, we'll be able to show a difference in distribution, representing this difference in or no structural abnormalities in the controls. These next plots are scatter plots of area versus flow. We see a positive correlation as expected, and we compared the slopes of the linear regression lines here and found no significant difference. But another interesting thing to look at is, even though we don't have many controls, there might be more variability in flow at a given area in the MS patients. As you can see, for like a given area, we see a larger range of flows than we do in the controls, and we'll need to get more controls in order to solidify that statement. And in conclusion, once again, we found no significant difference between, and this blood flow that we calculated was average over the cardiac cycle, and we found no significant difference between MS patients and controls. I didn't show it in the presentation, but the graph is on our poster if you want to look at it. We found no significant differences between the types of MS and area and blood flow. And we did see in the histogram that in area for MS, the MS group has this group of low area representing a structural abnormality of stenosis, narrowing. And that would be all. Thank you.
Thank you, Paul. It seems like we are still significantly challenged in the azygos. We have flows that don't appear, at least from your study, to be significantly different. We have 88% disease on IVUS. We're kind of still need to focus and drill down on this. But any questions for Paul? Thank you very much.
Okay, thank you.
Now we move to the last presentation from Dr. Andrew Duick, Prevalence of Chronic Cerebrospinal Venous Insufficiency in Patients with Multiple Sclerosis and Deficit Controls, a systematic review of the literature and meta-analysis. Thank you.
Thank you very much, and thank you everyone for the opportunity to present today and for your continued attention at the end of the session. My name is Andrew Duick. I'm a vascular surgeon at University of Toronto, and I'm just going to present to you our results. I suppose I'm doing this. Is that right? I put it on here before.
Last session will...
Oh, there it is.
You got it?
Yeah. You can use that if support. There we go. There was a list of co-authors involved with this work, and we're a group of vascular surgeons, radiologists, neurosurgeons, and internal medicine people. I'm going to skip through the background. Basically, we wanted to look at CCSVI as diagnosed by duplex and the literature surrounding that. Obviously, there's plenty of controversy. We did a literature search in pretty much the standard fashion, starting with electronic databases and then hand searching. And we have updated our data once, most recently in September 2011. The eligibility criteria are pretty standard. Original data and peer-reviewed publications had to use Doppler ultrasound, and there had to be an MS group and at least one healthy control group. Some papers study patients with other neurologic diseases as well. I'm not going to focus too much on this. We identified 8 studies, essentially. Probably the most important thing to take away from this is that only 3 used the ultrasound machine that Dr. Zamboni originally used to describe the condition, and whether or not that's significant, I suppose, is a matter of debate. Most studies tried to do blinding, or had some description of an attempt at blinding, but unfortunately none reported the success of blinding. Characteristics of the patients are really, I suppose you'll have to just take my word for it. There was nothing particularly that stood out in these patients, either in the MS patients or the healthy controls or the other neurologic diseases. I'm going to go through these. This is the core of the presentation, really, and what this is showing you an odds ratio. The vertical line at 1 would indicate that there's no difference between in CCSVI rates between healthy controls and MS patients. Anything towards the right, which you can see, indicates a positive association. The diamond, the middle of the diamond, represents the estimate, and then the tails are the 95% confidence intervals. I've highlighted 2 of the papers in throughout all of these. You're going to see a lot of these plots. One is Dr. Zamboni's original work, which is second from the bottom, and the last is Dr. Zavadnov's paper, which was the largest and most detailed in its description of methods. So these are the 5 parameters, and it is interesting to see the odds ratio jump around to see what was driving the positive diagnosis. So here's reflex with an odds ratio. This is a pooled odds ratio of 13.9. Here's flow in the deep cerebral veins reverse flow at 6.86. and another 6.86 for identified internal jugular stenosis. And then a little bit less is the no flow detected. Odds ratio was only 3, and about 3 again for reverted postural control. When you put them all together, what was the likelihood of a diagnosis of CCSVI comparing MS patients to healthy controls? The odds ratio was 12.79, and I have to say that's a staggering odds ratio. Typically, we see odds ratios in the ratio of 2 to 4, so that would be a very, very strong association. You can see also that there's some variability in the odds ratio estimates, with some finding no difference at all and some finding very strong correlation. What that means is we express that mathematically as heterogeneity. It doesn't mean that the quality of the studies varied widely. What it means is that the results of the studies varied widely. And when you see that, you try to search for the cause as to why that would be. We performed a few sensitivity analyses. Essentially, we just repeated the analysis, doing it in different ways. And one of the things that we anticipated that a lot of people might criticize this study and say, well, for this reason or that, it's inaccurate. So often when there's a new thing discovered, there's a hypothesis-generating report, and it's not unusual, actually, for that first report to be removed from analyses like this. So we decided to perform that analysis, so we removed Dr. Zamboni's original work and pooled the rest of them, and we still had a very strong positive odds ratio of 4, and statistically significant. We did this sensitivity analysis, which I like to call our most conservative analysis, and we removed Zamboni's work, and we also added in Depp's work. Depp didn't find any CCSVI in anyone, MS or otherwise, and for that reason there's a 0 in 2 of the cells of his data, and those zeros can't be added mathematically to the others. So you could criticize us, but we added a 1 to his findings artificially, just so that it could be included, and we still have an odds ratio of 4 even after adding that study in. Interpretation, well, there was obviously a large variation in the frequency of CCSVI observed. The odds ratios, as I said, were very strong. Even when we did our most conservative analysis, the odds ratio was still 4, which again is very high and very unusual in this kind of work. One troubling thing is the source of the heterogeneity is not clear, and I think by this time in this meeting we're all well aware and in well agreement that there needs to be a firmer and more precise definition of how to perform the ultrasound testing. But to be honest, I was looking very carefully for this when I was going through the studies, and all the studies describe pretty strong efforts to try to perform the test correctly and obtain the proper training. Of course, not all the studies use the UCID machine, and you don't know, or the result, or the methods rather, weren't as well described in all the studies as you might hope they could be. Sometimes small sample sizes throw off this kind of work, and some of the studies did have relatively small sample sizes. Just briefly, because I know we're out of time, but intra-observer variability was looked at by Dr. Zavadnov in his study and actually was quite high, and only a very small number of patients were changed from one category to another, which is also a sign of a diagnostic test that is working well. Here's just one thing that we noticed, or one member of our group pointed out. There does seem to be an interesting correlation between stage of disease or duration of disease and likelihood of CCSVI, at least in some of the reports that have been studied, and maybe suggests that the interplay is a little bit more complex than patient develops a lesion and patient develops MS. There may be a complex interplay or a positive feedback cycle where the disease itself is driving further lesions, which may drive the disease forward as well. Limitations of this kind of work are pretty obvious. We only had 10 studies. The blinding, unfortunately, was inconsistent and untested. And basically, I think the biggest limitation is the ultrasound technique was not described, and it's not very precisely, and has not been standardized. I don't think there's any publication bias in this kind of field, given how controversial it is. And unfortunately, we didn't have patient-level data, so we could not perform an individual patient-level meta-analysis, which would have been much more powerful statistically. Nevertheless, we found a large significant association. Definitive conclusions are a little difficult to draw from this data set, and I think we all agree we need a standardized ultrasound protocol and further data. We're supported by the CHR, and we're very grateful for that support. Thank you.
Thank you, Andrew. Any questions? That was very nice. Okay, if not...
Okay. Only 10 minutes for the last session, please, because many of attendees have flights later, so just 10 minutes stop and 3:15, huh? 3:15, okay.